So yesterday we have finished the class of large intestine, wherein we studied about various parts of the large intestine. Large intestine is one of the major part of the intestine in GIT, wherein we have many parts. The large intestine starts from the cecum at ileocecal junction. Cecum being the first part, next is the appendix, then the ascending colon, then the hepatic flexure, then transverse colon, then splenic flexure, descending colon, sigmoid colon, rectum, anal canal, and anus. So about 10 parts are there in the large intestine, which you have to by heart and should be able to reproduce. In the large intestine, we are having special the interior of the cecum is important, wherein ileocecal valve is opening in the right lateral plane, and 2 centimeters below that the appendicular opening is there on the posterior medial aspect of the cecum. And of course, if you want to know the surface anatomy of cecum, cecum is present below the intertubercular line and to the right of the right lateral plane. That's very easy. And then regarding the rectum, in the rectum we are having harstra inside the rectum, which are able to bear the weight of the fecal matter that is present in the rectum, that is stored in the rectum. In the anal canal, we are having the columns of Margagni, and then the anal valves, then the pectinate line, Hilton line, and then the anal verge. So the area, in the area of the columns of Margagni, it is lined by the columnar epithelium, whereas in between the pectinate line and Hilton's line, it is lined by the stratified squamous epithelium, and outside the Hilton line, it is lined by the skin only. So these are the major parts in the large intestine. Now coming to the extrahepatic biliary system, liver, pancreas and spleen. These are all the accessory organs of this digestive system which are going to discuss today. So the extrahepatic biliary apparatus or system consisting of structures which store and transmit bile into the duodenum. So this extrahepatic biliary apparatus is consisting of the structures which are outside the liver and which are helping in transporting the secretions of the liver into the duodenum. So now this system consisting of right and left hepatic ducts. So these hepatic ducts are emerging from the porta hepatis. They are collecting the secretions of the liver through various ductules, and finally a right and left big hepatic ducts are coming out in the porta hepatis from right and left lobes of the liver. A common hepatic duct is formed from the union of right and left hepatic ducts. So these right and left hepatic ducts unite to form a common hepatic duct. It turns downwards for about 3 centimeters and is joined on its right side at an acute angle by cystic duct. So this common hepatic duct is joined by a cystic duct to form the bile duct. So here we are showing this is the right lobe of the liver and this is the left lobe of the liver having various lobules, or you can say the surgical segments, where divided into 1, 2, 3, 4, then 5, 6, 7, 8. 8 surgical segments are the liver is divided into 8 surgical segments. These 8 surgical segments are directly draining into the right hepatic and left hepatic ducts, which are joining together to form common hepatic duct. This common hepatic duct, as it comes out of the porta hepatis and is going towards the duodenum, it is in the midway joined by a cystic duct to form the bile duct. So this bile duct is joined by a pancreatic duct, and finally it is forming the hepatopancreatic ampulla, which is opening on in the second part of the duodenum on major duodenal papillae. So this is the major duodenal papillae on which this ampulla of the hepatopancreatic duct is opening. So this is the pancreatic duct that is being added to the bile duct, common bile duct, forming the hepatopancreatic opening. Of course, this is the gallbladder, which is showing the fundus, the body, and then the neck, then the cystic duct coming out of the gallbladder, and it is joining the common hepatic duct, forming the bile duct. Then gallbladder stores and concentrates the bile which is secreted by the liver. So that is the function of the gallbladder. It stores and concentrates the bile which is secreted by the liver. The gallbladder is located at the inferior surface of the liver. I will show when the liver comes. I will show the place of the gallbladder on the inferior surface of the liver. It has fundus, body and neck. The neck constitutes to form the cystic duct. The neck continues to form the cystic duct, which joins with the common hepatic duct to form the bile duct. So in the gallbladder, what is going on is, it is going on concentration of the bile is going on. So here the wall of the gallbladder, which is a mucous membrane, it absorbs the water and sends the water in the blood circulation. So what is happening is, the bile that is secreted in the liver is being concentrated in the gallbladder. Now structure of the gallbladder. The wall of the gallbladder shows three layers. The indus mucous membrane thrown into small folds and lined by simple columnar epithelium with microvilli on the luminal surface. So the microvilli, as you know, villi are the absorption surfaces which is going to absorb the fluid from the lumen, from the lumen of the gallbladder. So the bile that is secreted in the liver is coming to the gallbladder first, and there it is stored, and while it is being stored, the water is being absorbed from this bile, and bile is concentrated in the gallbladder. To absorb this water only, it is having a simple columnar epithelium with microvilli. So the mucous membrane of the gallbladder is having simple columnar epithelium with microvilli in order to absorb water and concentrate bile. Deep to the mucous membrane is the lamina propria. Muscularis mucosa and submucosa are absent. Here there is no purpose for the mucous membrane to move hither and thither. So muscularis mucosa is absent, and of course there are no glands here, so submucosa is absent. So here we are having mucous membrane supported by lamina propria, then fibromuscular coat, which consisting of fibroelastic fibers and smooth muscle fibers, and serosa will be outside. So it is also having same layers as other parts of the GIT, that is the mucosa, submucosa, then the muscularis proper and serosa. Whereas in the mucosa, in the other parts of the intestine, we are having a epithelium, then lamina propria and muscularis mucosa. Whereas in the gallbladder, as there is no function for folding, the muscularis mucosa is gone. Only epithelium and lamina propria is there, and submucosa is also absent in the gallbladder. So we are having immediately after the mucous membrane and lamina propria, after mucosa, we are having directly the fibromuscular coat consisting of fibroelastic fibers and smooth muscle fibers. Then outside we are having the serosa as in any other gastrointestinal organs. Then bile duct. This bile duct is formed by the union of cystic duct and common hepatic duct. So I told you the common hepatic duct is formed by the union of right and left hepatic ducts, which are coming out of the liver through the porta hepatis. So once they have come out, they are forming the common bile duct, common hepatic duct, which is being joined by the cystic duct to form the bile duct. Now this descends on the right free margin of the lesser omentum along the portal vein and hepatic artery. It passes deep to the first part of the duodenum and head of pancreas. So this is descending from the porta hepatis towards the duodenum, and it passes behind the first part of the duodenum and head of the pancreas. It joins the pancreatic duct and opens into the second part of the duodenum on the summit of major duodenal papilla. So this bile duct is being joined by the pancreatic duct, and it opens into the second part of the duodenum on the summit of major duodenal papilla. So here we are showing this is common bile duct coming on the posterior aspect of the first part of the duodenum and then entering the pancreas. Then at the level of the major duodenal papillae, you know that it is present from 8 to 10 centimeters from the pyloric sphincter. So in the second part of the duodenum, It is present 8 to 10 centimeters from the pyloric sphincter, and here on the major duodenal papillae we are seeing the opening of the ampulla of the hepatopancreatic duct. So here the pancreatic duct is being added to the common bile duct and forming a common ampulla which is being opening into the major duodenal papillae. Whereas on the minor duodenal papillae, the accessory pancreatic duct is opening. This one is the minor duodenal papillae. These are present on the wall of the duodenum, medial wall of the duodenum. Then applied anatomy. A common, so now in the extrahepatic biliary system, we have seen that two hepatic ducts are coming, one from right and one from left, and forming a common hepatic duct. And common hepatic duct coming outwards towards the duodenum, and in midway it is joined by the cystic duct from the gallbladder at right angles on its right side, and then this bile duct is formed by the union of the common hepatic duct and cystic duct, and this bile duct coming on the posterior aspect of the first part of the duodenum, then entering the pancreas and opening on the medial aspect of the second part of the duodenum on the major duodenal papillae, which is about 8 to 10 centimeters from the pyloric sphincter. So this major duodenal papillae is having the opening of the common hepatopancreatic duct, which is pouring the secretions of the liver as well as the pancreas into the second part of the duodenum. And above this major duodenal papillae, there is one more papillae, minor duodenal papillae, which is about 6 to 8 centimeters from the pylorus, and it is having the opening of the minor pancreatic duct. So major duodenal papillae is from is present at 8 to 10 centimeters for the pyloric sphincter, whereas minor duodenal papillae is just above, that means it is 6 to 8 centimeters from the pyloric sphincter. So major duodenal papillae is having opening of the common hepatopancreatic duct, whereas the minor duodenal papillae is having opening of the extra pancreatic duct, accessory pancreatic duct. Now applied anatomy. A common clinical problem of the gallbladder is development of gallstones. So the clinical problem in gallbladder is development of gallstones. Bile is composed of various salts, pigments and cholesterol. Normally cholesterol remains in solution, but under certain conditions they precipitate to form solid crystals. Large crystals may block the bile duct and have to be surgically removed. So gallstones, as I told you, the function of gallbladder is to concentrate the bile. So in course of concentration, sometimes if it is not expelled from the gallbladder, it is concentrated more and more, such that the contents, the solutes in the solution may become solidified. So there is a chance that the cholesterol may solidify and become stones, crystals. Large crystals may block the bile duct and have to be surgically removed. Cholecystitis, a painful condition caused by the blockage of the cystic or common bile duct by gallstones. So when these gallstones are formed, if they block the cystic duct or common hepatic duct, common bile duct, what is happening? The secretions that are present in the gallbladder are not allowed to go. So thereby there is a distension and there is a pain. So that's about the extrahepatic biliary system, consisting of common hepatic duct, then the gallbladder, then the cystic duct joining the common hepatic duct, forming the bile duct, the bile duct coming out of the porta hepatis and traveling on the posterior aspect of the first part of the duodenum, piercing the pancreas, and in the pancreas it is opening into the duodenum on the major duodenal papillae, and then here it is also being joined by the pancreatic duct. So common hepatopancreatic duct is opening in the major duodenal papillae. So that's about the gallbladder, and then the extrahepatic biliary system. Then as the gallbladder is concentrating this bile, there is a chance that sometimes the solutes may become solidified and the crystals of cholesterol may form. These crystals of cholesterol may obstruct the common bile duct, may obstruct the cystic duct, giving rise to distension of the gallbladder and severe pain. And sometimes cystitis, that is the inflammation of the gallbladder, can occur either due to infection or due to obstruction. That is a very severe painful condition. Now we go for the liver. Liver is the largest gland of the body. It has metabolic, synthetic, excretory, protective and storage function. So what is metabolic function of the liver? It is conversion of the food material that is being absorbed into the small intestine into storable substances. So the carbohydrates, the proteins and fats that have been absorbed in the small intestine are converted into substances which can be stored in the liver or in the body. Then synthetic. This liver synthesizes many enzymes and many hormones. So that is the synthetic function of the liver. Then excretory. Liver excretes certain drugs in the bile such that it will be reaching the small intestine from the large intestine, maybe coming out through the feces. Then protective. Liver protects the body by producing immunoglobulins. Storage function. Liver stores the fat, that is the carbohydrates that are modified into fat or fats that are modified into storable form. So thus the liver is having a metabolic, synthetic, excretory, protective and storage functions. Then structure. Liver is a wedge-shaped structure situated in the right upper quadrant of the abdomen. So liver is a wedge-shaped structure situated in the right upper quadrant of the abdomen. It weighs about 1.4 to 1.8 kg in adult male and 1.2 to 1.4 kg in adult female. Then external features. Liver presents 5 surfaces: superior, inferior, anterior, right and posterior. Okay, liver is having a superior surface, inferior surface, anterior surface, posterior surface. In addition, it is having a right surface also. The superior surface is separated from the heart and lungs by diaphragm. So superior surface is almost attached to the diaphragm, and above the diaphragm we are having the heart and lungs. So we say that superior surface is separated from heart and lungs by the diaphragm. So here, this is the diaphragm. Above this diaphragm, you will be seeing the heart in the almost in the mediastinum and lungs on either side. So this diaphragm is separating the superior surface of the liver from the heart and lungs. Then it is wedge shaped. Okay, we are showing this is a wedge shaped one, which is thicker on the right side as well as on the superior aspect, and thinner on the left side as well as the inferior aspect. Then okay, it is having a superior surface, then the anterior surface, the right surface, then the posterior surface and inferior surface. Okay, we will see. Its anterior surface is related to the anterior abdominal wall. The posterior and inferior surface are related to the many abdominal viscera. Left lobe is related to the esophagus and stomach. The right lobe is related to the second part of the duodenum, right kidney, right suprarenal gland and right flexure. So these are the posterior and inferior surface of the left lobe is related to the esophagus and stomach, whereas the posterior and inferior surface of the right lobe is related to the right kidney, right suprarenal and right flexure of the colon. The bare area is not covered with peritoneum and is in direct contact with the diaphragm. So here, this part that is coming in direct contact with the diaphragm, we are seeing bare area. So this is bare area. So this part, the left triangular ligament bounded by the left triangular ligament, coronary ligament, the inferior vena cava. This part is the bare area, and again on this side, this is the bare area. Bare area we are showing here also. We are showing this is bare area on the this is on the right side, this is on the left side. So that is in between the left triangular ligament, coronary ligament, then the right triangular ligament and coronary ligament. We are having the bare area. This is the falciform ligament, whereas the base of the fissure for the ligamentum teres is also having the bare area. And also the base of the inferior vena cava is also having bare area, and of course gallbladder, and these are the various bare areas present in the liver. Now anterior surface is related to the anterior abdominal wall, posterior and inferior surface are related to the many abdominal viscera, left lobe is related to the esophagus and stomach, right lobe is related to the second part of the duodenum, kidney, right suprarenal and right flexure. The bare area is not covered by the peritoneum and is in direct contact with the diaphragm. So here, this is the bare area that is in direct contact with the diaphragm. Then the left lobe is in relation to the, this is the esophagus, then this is the stomach, and then we are having this is the impression of the left colic flexure, and then on the right side we are having the impression of the duodenum. This is the caudate lobe, and where is the duodenum? This part it will be here. This is the impression of the duodenum, and then this is the impression of the renal impression, suprarenal. So suprarenal, renal, and duodenum are the, and of course colic flexure are the four organs that are in relation to the right lobe. Whereas on the left lobe it is the gastric impression, esophageal impression, and only two we are having on the left side. And then of course you are seeing the caudate lobe, then you are seeing the quadrate lobe, and then by the side of the quadrate lobe you are seeing the gallbladder, and of course base of the gallbladder you are seeing the inferior vena cava here in relation, in between the almost superior and posterior surfaces, and then you are seeing the falciform ligamentum, the fissure for the ligamentum venosum, and this is the fissure for ligamentum teres, and then this is the falciform ligament present here. It also presents the fissure for ligamentum teres at the inferior surface and fissure for ligamentum venosum at the posterior surface. Following peritoneal ligaments are attached to the liver: the falciform ligament, right and left triangular ligament, and coronary ligament. So this is the falciform ligament, and we are seeing this is the coronary ligament, and here we are seeing the right triangular ligament and left triangular ligament. So falciform ligament, coronary ligament, and right triangular ligament and left triangular ligament. Liver also presents caudate and caudate lobes. I have shown you the caudate and caudate lobe. Caudate lobe is just by the side of the gallbladder, whereas caudate lobe is by the side of the inferior vena cava on the superior side, and whereas caudate lobe is on the inferior aspect. The porta hepatis is the hilum of the liver, in which right and left pancreatic ducts, right and left branches of portal vein and hepatic artery present. So this is the porta hepatis present between the caudate lobe and caudate lobe, and of course here the gallbladder is also forming the lower boundary of this porta hepatis. This is having the hepatic artery proper, that is the right and left hepatic branches also there, and then the common hepatic duct which is having right and left hepatic ducts, and then the portal vein. So these are the structures present in the porta hepatis. That is common bile duct, common hepatic duct, common hepatic duct is not the bile duct, common hepatic duct, then common hepatic artery and portal vein. A gallbladder fossa is present which enlarges the gallbladder. Here the gallbladder fossa is present on the inferior aspect where the gallbladder is accommodated. This gallbladder fossa you can say present between the quadrate lobe and right lobe of the liver. Quadrate lobe and right lobe of the, okay, quadrate lobe and right lobe of the liver. Again, same thing we are showing the posterior view and the bed of the liver. So from here the liver is removed and we are seeing the posterior view. So here bare area, we are seeing the bare area on the liver, and here we are seeing diaphragm that is directly attached to the liver. Whereas here we are seeing the coronary ligament, and in between this left triangular ligament, coronary ligament and right triangular ligament, this area we are having bare area. Yes, this is on the liver bed, whereas on the liver we are seeing this bare area between the left triangle, this right triangle and coronary ligament. So this part is the bare area here, and this is here which is attached to the diaphragm. Then we are seeing the gallbladder here, and then we are seeing the this is the falciform ligament and fissure ligamentum venosum. Then we are seeing the impression. So here we are seeing the stomach. So this part will be the gastric impression. Then here we are seeing the duodenum. Here will be the impression for the duodenum. Here we are seeing the esophagus. This part will be this is on left side. Here this will be the impression of the esophagus. This duodenum is on left side. Here the impression of the duodenum, whereas this is the impression of the stomach. So like that, actually here we can see here. So here this is the gastric impression, and this is the impression of the esophagus. This is the impression of the duodenum, and then of course you are seeing the renal impression, suprarenal impression. Here the colic impression. All these things can be seen in the posterior inferior aspect of the liver or visceral surface of the liver. Now arterial supply. 20% of the blood is received from the hepatic artery, oxygenated blood, and hepatic artery is a branch of celiac trunk of the abdominal artery, and 80% of the blood from the portal vein. So the most of the blood supplied to the liver is from the portal vein, that's about 80%, and only 20% of it is coming through the hepatic artery from the celiac trunk, that is supplying oxygen to the liver. Whereas this 80% of blood that is coming from the portal vein is getting the nutrients that are being absorbed in the intestine, and they are being transported to the liver, where they can be converted to the substances which can be utilized by the body or stored in the body. So that is the function of the liver, that has to convert a metabolic function, that is has to convert this absorbed food material into utilizable form or storable form, and of course then it stores. So its function is storage function is also there. Venous drainage. The venous blood is drained by hepatic veins which drain into inferior vena cava. So venous blood is drained into hepatic veins which are draining into the inferior vena cava. Microscopic structure of the liver. The connective tissue covering of the liver is called Glissen's capsule. Connective tissue divides the liver into liver substance into number of lobules. So there is a connective tissue covering over the liver, which we are calling it as Glissen's capsule. It is made up of pure connective tissue, and then this is going deep into the substance of the liver, thereby dividing the liver into lobules. Then this liver presents plenty of hepatic lobules. So there are many number of hepatic lobules which are hexagonal in shape, and the center of each lobule is served by a vein. So this each lobule is having a vein in the center, central vein you call it as. Liver cells are polygonal in shape, arranged in laminae which radiate from the central vein. So this liver cells, which we are calling as hepatocytes, are polygonal in shape and arranged in lamina, that is a row, which radiate from the central vein. So these hepatocytes are radiating like rays of sun from the central vein. These hepatic lamina consisting of two rows of cells with bile canaliculi intervening with them. So this lamina is consisting of two rays, upper lower layer of the hepatocytes. In between we are having bile canaliculi which are coming from these hepatocytes. So here we are showing the microscopic structure of the liver, wherein each lobule is hexagonal. The cells, hepatocytes, are radiating from the central vein. From the central vein they are radiating as a double row of hepatocytes. In between this double row we are having bile canaliculi. Then at the periphery we are having portal tride, that is a hepatic artery, bile duct and portal vein on all the 6 corners of this hexagonal shaped lobule. Then the space between the adjacent hepatic laminae is occupied by sinusoids. So hepatic lamina, I told you, is a bilaminar hepatocytes. Hepatocytes are arranged in 2 rows with biliary canaliculi in between. Then in between the adjacent hepatic laminae there is a space which we are calling it as sinusoid. The central veins join successively to form hepatic veins, which open into the inferior vena cava. So central veins of each hepatic lobule, hexagonal lobule, are joining successively to form hepatic veins, which open into the inferior vena cava. The bile canaliculi present between the rows of hepatocytes receive bile, which open into the interlobular bile ducts of portal tride. So the bile canaliculi, which are receiving bile secreted by the hepatocytes, are transporting this bile to the bile ductules that are present in the portal side on the periphery of this hexagonal shaped lobule. Then space of this is present between the walls of sinusoid and hepatic laminae. So sinusoid, I told you, in between the 2 laminae there is sinusoid. Sinusoid is a space which is filled with blood and lined by endothelium with more gaps in between the cells. And then the space contains blood plasma, which open into space of mall, which is present in portal canal. That I will show you. The lymphatics of liver begin at this space of mall. So here we are seeing this is a hepatic lamina having 2 layers of cells with canal of herring or bile duct in between. So here the secretions of these hepatocytes are poured into this bile duct, and this bile is coming into the bile duct of the portal tride, and then this canaliculi is excreting into the bile duct of the portal tride. Then we are having space of disc on either side of the sinusoid. There is a sinusoid in between the laminae, hepatic lamina. Also, this is one hepatic lamina. There is another hepatic lamina. In between, there is a sinusoid space which is connecting the portal vein and central vein. And this sinusoid space is there is a space between these sinusoids and the hepatocytes, which we are calling it as space of disc. And this space of disc is directly entering the space of mall, which is present in the portal tride outside this portal vein, bile duct and the hepatic artery, and inside this hepatocytes that is surrounding the sinusoid. So this space of disc is present in the sinusoid itself. This is the continuation, sinusoid itself, and then the space of disc, space of mall, space of disc. So this space of disc open into the space of mall, and this space of mall together form lymphatic vessels. Now here we are showing the laminae, hepatic laminae radiating from a central vein. This is the central vein. From here, the lamina are radiating, and each lamina is having two rows of hepatic cells with biliary canaliculi in between. This biliary canaliculi will open into the bile duct of the portal tride present on the angles of the hexagonal shaped hepatic lobule. Then Kuffer cells or reticuloendothelial cells present in the walls of sinusoid. Portal lobule of liver is a triangular area supplied by structures of the portal canal, and hence it consisting of centrally placed portal canal and central vein at three corners. So portal lobule is a different one, apart from hepatic lobule, which is surrounding a central vein, whereas this portal lobule is a triangular area supplied by structures of a portal canal. So this is surrounding a portal canal. On the three sides of this portal canal, we are seeing the portal lobule, and it consisting of centrally placed portal canal and central vein at the periphery. So here we say this part is the hepatic lobule, whereas when you say these three hepatic, these three hepatic lobules encircling this portal canal, we are calling it as portal lobule. This part is the portal lobule, wherein 3, 4 or up to 6 hepatic lobules are surrounding this portal canal. So this is the portal lobule, and this part is the hepatic lobule. So at the center of the hepatic lobule we are having a central vein. At the center of the portal lobule we are having a portal vein. The spaces between the adjacent hepatic lamina is occupied by sinusoids, I have shown you already. The periphery of the hepatic lobules present portal canals. Each portal canal consisting of three structures: a radial portal vein, a radical portal vein, a branch of hepatic artery, interlobular bile duct. So this is the portal tride. The periphery of hepatic lobule presents a portal canal or portal tride, and each portal tride is having a hepatic artery, a portal vein, and a bile duct. So this is the bile duct, this is the portal vein, this big one, and this is the hepatic artery. So how to differentiate this duct, vein, and artery? The duct is having, the vein is having a wide space with a thin wall, whereas duct is having thick wall and a small space. And similarly, the artery is also having a thick wall and the space. The space of the artery is regularly circular, whereas the space of duct is not so. The sinusoids between hepatic lamina receive blood from both portal vein and hepatic artery. After providing nutrition to the hepatocytes, the blood of the sinusoids drain into the central vein. Central veins join successively to form hepatic veins, which open into the inferior canal. The bile canaliculi present between the rows of hepatocytes receive bile, which open into the intralobular bile ducts of portal tride. Space of disc is present between the balls of sinusoid and hepatic laminae. These spaces contain blood plasma, which open into space of mall, which is present at portal canal. Again, I'll show you. Here, this is the space of disc present between the hepatic laminae and sinusoid. So in between the two hepatic laminae, I told you there is sinusoid. Sinusoids is nothing but the space occupied by the blood and covered by endothelium, which are loosely arranged. That is, there are much open spaces that can allow the fluid inside out and outside in. So these sinusoids are connecting the central vein and portal vein. Central vein is present in the center of the hepatic lobule, whereas portal vein is present at the periphery of the hepatic lobule. So from periphery to the center, these sinusoids are there, and by the side of the sinusoids are present in between the hepatocytes, and the space of disc is present between hepatocyte and sinusoid. So here the lymph can be collected in the space of disc. This space of disc opens directly into the space of mall, which is present in between the hepatocytes surrounding the portal tride and the structure of the portal trides. That means there is a space between these hepatocytes and this structures of the portal tride. This space we are calling as space of mall. So this is space of disc, this is the space of mall. So this fluid that is collected in the space of disc, that is by the side of in between the hepatocytes and the sinusoids, that is going into the space of mall in the portal tride, and from there lymphatic starts and this lymphatics drain gradually. The Kuffer cells and reticuloendothelial cells present in the walls of the sinusoid. Kuffer cells are present in the walls of the sinusoids. These are a type of reticuloendothelial cells. Portal lobule of the liver is triangular area supplied by the structures of the portal canal. Hence, it consists of centrally placed portal canal and central vein at the three peripheries. Applied anatomy. Clinically, hepatocellular damage is manifested as jaundice. So, if the cells of the liver are damaged, there is a chance of jaundice can occur. Cirrhosis of the liver is a condition in which liver hardens and shrinks due to the fibrosis, often in chronic alcoholism. So, in chronic alcoholism, the byproduct of the alcohol mechanism, aldehyde, is acting on the liver and killing some liver cells which are being replaced by the fibrous connective tissue. This fibrous connective tissue, as it increases, it gradually shrinks the size of liver. That is the condition called cirrhosis. Cirrhosis is a condition wherein the hepatocytes are being gradually replaced by fibrosis. Fibers, because they are being killed and being replaced. It leads to portal hypertension. After suffering for several years, the patient dies in hepatic failure. So in cirrhosis is a chronic condition where the patient dies after several years of suffering. So that's about the liver. So in the liver, mainly we see that liver is a structure, a big gland which is present in the right hypochondrium of the abdomen and which is having functions like metabolism, storage, the protection of enzymes, production of hormones. All these things are various functions of the liver. And liver consisting of a capsule which enters the substance of the liver and divides the liver into lobules. Each lobule is hexagonal in shape with a central vein. At the periphery of this hexagonal shape, we are having portal trides. Portal tride is having a portal vein, a common hepatic duct, hepatic artery, and bile duct. So this there is a space of mall, space of disc. Space of disc is present in between the sinusoids and the hepatic lamina, and space of mall is present in the portal tride, wherein the space of disc is opening into the space of mall, and from the space of mall, lymphatics of the liver starts. So now, then the blood that has come through the hepatic artery is passing through the hepatocytes, the lamina of the hepatocytes, then reaches the central vein. From there it is being collected into the portal vein and it is going out. From there it is connected into the hepatic vein, and this hepatic vein joins the inferior vena cava. So that's about the liver. Pancreas. Pancreas is both exocrine and endocrine gland. So pancreas, usually glands are either exocrine or endocrine, and there are certain glands like pancreas are both exocrine and endocrine. This pancreas is having a function of exocrine. That means the secretions of pancreas are passing through the pancreatic duct to the second part of the duodenum, whereas endocrine production of the pancreas are directly joining the blood circulation. So exocrine part secretes the pancreatic juice and endocrine part secretes the insulin and glucagon. Pancreas is transversely placed in the posterior abdominal wall, retroperitoneally at the level of the first and second lumbar vertebra. It is a retort-shaped structure about 6 to 8 inches long and weighs about 90 grams. So here we are showing the pancreas. In the retort we are having a wide part and a beak. So this is the beak that is formed by the body and tail, whereas this wide part is formed by the head and uncinate process. This head and uncinate process are forming the body of the retort, and this beak is formed by the body and tail of the pancreas. And then this pancreas is situated in the C of the duodenum, and it is extending from this right part of the abdomen to the left part till it reaches the hilum of the spleen. The tail is present at the hilum of the spleen. So it's about 6 to 8 inches long and weighs about 90 grams. And then it is having a main pancreatic duct which is joining the common bile duct and to open into the major duodenal papillae, which is present on the medial wall of the second part of the duodenum, 8 to 10 centimeters from the pyloric sphincter. Whereas there is one more minor duodenal papillae which is having the opening of accessory pancreatic duct, which is present about 6 to 8 centimeters from the pyloric sphincter. So this is the section of the, transverse section of the pancreas, wherein, or you can say, the anterior part of the pancreas is removed and the exposing the pancreatic duct and the common bile duct opening into the second part of the duodenum. And this is the histological microscopic structure of the pancreas, wherein there are normal serous acini. These are all the serous acini of the pancreas, and these are the islets of pancreas, pancreatic islets. These are the pancreatic islets with paler cells arranged irregularly and very close to each other, whereas the exocrine part of the pancreas is the cells are arranged regularly like acini. These pyramidal shaped cells with a round nucleus towards their base. Whereas here cells are of different size and they are arranged irregularly and they are forming the pancreatic islets, where there are alpha cells, beta cells and gamma cells which are secreting insulin, glucagon and other things. Now parts of this pancreas, it is having head with ulcerate process, neck, body with tuberomental and tail. So this is the head with the ulcerate process, body with the tuberomental and then the tail. The head of the pancreas is situated within the concavity of the duodenum. Posteriorly, it is related to the inferior vena cava and bile duct. So head of the pancreas is related, is situated in the concavity of the duodenum, and behind we are seeing the inferior vena cava and bile duct. Neck is the constricted part between the head and body, and the portal vein is found behind the neck. So portal vein is found behind this part of the neck. This part is the neck, which is constricted part, and portal vein is found behind this neck by the joining of the splenic vein and the superior mesenteric vein. The body of the pancreas is anteriorly overlapped by the stomach. Posteriorly, it is related to the abdominal wall, left kidney and left suprarenal gland. So it is anteriorly related to the overlapped by the stomach. So pancreas is anteriorly overlapped by the stomach. Posteriorly, it is related to the abdominal aorta, left kidney and left suprarenal. Tail extends into the hilum of the spleen in the peritoneal fold called lineorenal ligament and is accompanied by splenic artery. Structurally, pancreas presents pancreatic acini which secrete pancreatic juice. The acini are lined by pyramidal shaped cells with a round nucleus placed towards the basement membrane. The islets of plankton are small isolated masses throughout the pancreas but more towards the tail. They secrete hormones like insulin and glucagon. So this is the acini of the pancreas, which are having the pyramidal shaped cells with a round nucleus toward their base, and these are the islets of pancreas, which are surrounded by a thin fibrous layer, and then inside we are having different types of cells scattered, not arranged like acini. Okay, these islets of pancreas are more toward the tail. Pancreatic duct, the pancreatic juice is drained by pancreatic duct, which joins the bile duct to form hepatopancreatic ampulla, and it opens on the second part of the duodenum, the summit of major duodenal papillae. The hepatopancreatic ampulla opens on the second part of the duodenum, on the summit of major duodenal papillae. An accessory pancreatic duct may be present, which opens on minor duodenal papillae. Pancreas is supplied by spleenic artery, superior and inferior pancreaticoduodenal arteries. The venous blood drains into the portal vein. So, the blood supply of pancreas is by splenic artery and inferior and superior pancreaticoduodenal arteries. The venous drainage is into the portal vein. Applied anatomy. Diabetes mellitus is the deficiency of the insulin, a secretion of the pancreatic islets, which is characterized by polyurea. The diabetes mellitus is characterized by polyurea, polydipsia, and polyphasia, glycosuria, and hyperglycemia. So, there are 5 characteristic features of the diabetes mellitus, which is occurring due to the deficiency of the insulin, which is a secretion product of the islets of the pancreas. Now, these patients are susceptible for infection, which is quite resistant to the treatment. So, the infection that is occurring in diabetes mellitus patient is not easily treatable. So, first you have to control the diabetes mellitus, then only you can treat this infection and control the bacteria. Otherwise, the bacteria will be having plenty of carbohydrates to grow on, and the infection will not be controlled by any number of antibiotics that are given without controlling the diabetes mellitus. So, first you have to replace the insulin, or you have to stimulate the pancreatic islets to produce more insulin such that the glucose levels in the blood are normalized. That is, hyperglycemia is gone and glycosuria is gone. Then only you can control the infection. Then acute pancreatitis is a grave disease. Acute pancreatitis is a very dangerous disease. Grave disease means that can lead to death. It begins with acute agonizing pain in the epigastrium, piercing deep to the back, associated with the vomiting, cyanosis, and collapse of the person. So, this acute pancreatitis can begin with a agonizing pain in the epigastrium, which is associated with vomiting, cyanosis, and collapse of the person. So, it is a grave disease. That is that disease which can lead to death soon. Carcinoma is common in head of the pancreas. The pancreatic carcinoma has worst prognosis of all types of cancers due to spongy vascular nature of this artery. So, carcinoma is another disease which is common in head of the pancreas, and this carcinoma is dangerous because the spongy and vascular nature. The pancreas is very vascular, so the carcinoma can spread widely, and at the same time, the carcinoma can act upon the pancreas itself, controlling the production of insulin and other things, such that again the loss of insulin means diabetes mellitus, and then the severe proximity to the infection. So they are prone to infection, and the infection can lead to death. Now it is the last one. So in the pancreas, we learned that the pancreas is present in the retroperitoneal, is a retroperitoneal structure present in the posterior abdominal wall around the level of the L1, L2, and then it is traveling from the C of the duodenum to the left side at the spleen of the hilum of the spleen. So this pancreas is a retort structure with head and uncinate process forming the body of the retort, and the body and tail forming the stem of the retort. And then it is having the two types of cells, the exocrine cells and endocrine cells. The exocrine cells are forming acini in the pancreas, and their secretion is collected by the pancreatic duct and poured into the duodenum at major duodenal papillae along with the common bile duct. And then the exocrine secretion of the pancreas is from the islets of pancreas, which are isolated bodies of cells which can be easily distinguished from the acini of the exocrine pancreas. And these islets of pancreas, islets of Langerhans, islets of pancreas are surrounded by a thin layer of connective tissue, and then the secretions of these islets are directly going into the bloodstream. So it is insulin and glucagon that is directly going to the bloodstream that controls the mechanism, the controlling the carbohydrate mechanism. Then now the clinical aspect of the pancreas is the first thing is diabetes mellitus. Because of the lack of the insulin, diabetes mellitus can occur, wherein the patient is prone to infection. The infection cannot be controlled unless the diabetes mellitus is first controlled. And then the second one is the pancreatitis. This is one wherein the inflammation of the pancreas is occurring, which is an acute disease and which is very painful, and this also may be fatal. And pancreatic carcinoma is definitely fatal. It is occurring more in the head of the pancreas, and this is spreading throughout the pancreas and to other parts of the body because of the highly vascular nature of the pancreas and because of the spongy nature of the pancreas. So then the spleen. Spleen is situated in the abdominal cavity along the long axis of the 10th rib. So it is situated in the abdominal cavity on the left side along the long axis of the left 10th rib. Then it presents an expanded anterior end and a pointed posterior end. It has a convex diaphragmatic surface which is related to the diaphragm at the level of the 9th, 10th and 11th ribs. Its visceral surface presents a hilum through which splenic vessels enter the spleen through the peritoneal ligament, that is the lineorenal ligament. Then the visceral surface shows the following impressions: the gastric impression for the fundus of the stomach, the renal impression for the left kidney, the colonic impression for left flexure of the colon. The tail of the pancreas extends into the lower part of the hilum. So the visceral surface shows the impressions of the gastric impression, renal impression and colonic impression. And the tail of the pancreas is extending into the lower part of the hilum. Blood supply, the spleen is supplied by the splenic artery, which is a branch of the celiac trunk. Splenic veins from the portal vein after joining with the superior mesenteric vein at the back of the head of the pancreas, neck of the pancreas. Okay, now the spleen we are showing, this is the diaphragmatic surface, and this is the visceral surface wherein there is a gastric impression, there is hilum and pancreas, there is a renal impression and there is a colic impression. So in the diaphragmatic surface there are it is only directly related to the diaphragm and 9th, 10th, 11th ribs, whereas in the visceral surface it is related to the stomach, to the left kidney and to the colic impression, that is the left colic flexure, that is the splenic flexure. Now inside the spleen we are having a hilum is there, splenic trabeculae, fibrous capsule. Okay, this is not being shown, the white and red bulb, but here we are seeing the lineorenal ligament. Gastrosplenic ligament, okay, then suprarenal left kidney, this part will be the lineorenal ligament. So this lineorenal ligament between the spleen and the kidney, lineorenal ligament, and this is allowing the various blood vessels that is going into the spleen. The interior of the spleen shows red pulp and white pulp. The white pulp is an aggregation of lymphocytes around an arteriole. The remaining area of the spleen shows cut sections of the blood vessels with a red pulp which is made up of red blood corpuscles, lymphocytes and macrophages. All these cells rest on reticular type of connective tissue. So here we are showing the white pulp and the red pulp. Red pulp is having the various contents of the blood vessels and sinusoids, veins and arterioles, whereas the white pulp is having a centrally placed arteriole and number of lymphocytes that are surrounding the arteriole. This is the white pulp. These are the white pulps, and of course this is also white pulp, and this is the red pulp. Functions of the spleen. It is multiplication of lymphocytes, destruction of the old red blood cells. The spleen is otherwise called graveyard of red blood cells. In fetal life, production of all blood cells. Applied anatomy. Spleen is enlarged in infections such as malaria, typhoid. This condition is called splenomegaly. The spleen is enlarging from the left hypochondrium towards the umbilicus and towards the right iliac fossa. That is the direction in which enlarged spleen can be palpated. So that finishes our extrahepatic biliary system. Then the liver, the pancreas and spleen. That's it. Thank you.